Obviously, I should have baked some goodies to attract more folks. So I will try to make it interesting to not put you guys to sleep. And by the way, if anyone came here for 403B, this is not it. This is not for your retirement investment to make money. This is for the hospital. I will join you in the 403B discussion. I think it's down the hall. So, glad everyone could make it. My talk today will be about the 340B drug pricing program. And I think for as long as Erlanger has participated in this program, I feel like it was a detriment that our clinical and provider personnel in the hospital does not know too much about the program and how much impact it has. So instead of just seeing the 340B team as the nagging folks that comes around and gives you rules and specifications, I think this will provide a little bit of education to kind of know what is really impacting our hospital system. Hopefully, I'll be able to provide you an overall intention of this program. Because of its complexities, I think that's why not a lot of folks know about it. So we'll go over a few highlights as to why it is such a complex program and it makes it harder to get folks to kind of wrap their heads around it. And lastly, to realize, take this to what you're practicing and see why it's important to your health system. I have no disclosures. My opinions are my own and not necessarily of Erlanger's. So what is the 340B program? I chuckle when I get some answers from folks on this. I get a variety of answers. Basically, well, it's a program the hospital saves money, or, oh, it's that program that patients get free drugs from that retail store in our hospital. Or, oh, it's that team that goes around and makes sure that I have to scan all the NDCs correctly. Or from eChart, I love it. It's that team that has horrible projects that we really don't want to participate in. So all of those is actually correct. Not too much on the eChart piece, but I think the program encompasses so much that people get bits and pieces of it. And hopefully today you have a broader idea of what the program touches and why it's so important. So essentially with this program, it's a federal government program. So it essentially provides outpatient drug discounts to folks who qualify. So when we're talking about covered entities, these are locations that have met certain requirements. These are hospitals that are serving patients in our community that are low income, uninsured. So you're talking about hospitals that meet that requirement of taking that community upload of uncompensated, uninsured care. This is what the program is for. It's held by Hersa, which falls administered by the Office of Pharmacy Affairs, which is ultimately under the Department of Health and Services. Essentially, I think the biggest confusion in the program is how it's funded. And depending on the resources that you look into, there's a lot of, I guess, partial opinion as to why the program is controversial and should be under some scrutiny. It depends on which side you take and read the opinions from. Essentially, the funding from this program comes from drug manufacturers. We are getting discounts from drug manufacturers. This is where that financial piece comes into play. This is not from taxpayer money. This is not from our government. So you'll hear a lot of remarks that throws your opinion and understanding of the program and why it's important. And essentially, with this program, the intention is to allow our hospital entities to get discounted drugs in two areas, one within our hospital outpatient areas, and the other is extended to contract pharmacy. So the contract pharmacy realm is where you have your patients taking their prescriptions out to all of your retail stores, your specialty stores. So we're talking about CVS, Walgreens, Accredo, wherever our patients are going. Because we participate in this program, we're able to realize the savings when they take their prescriptions there. So you've got that avenue within the hospital to pull savings in from, and you've got the contract pharmacy. And I think that causes a lot of confusion as to where the financial savings come into, because it expands beyond the hospital. So also it expands your risk beyond the hospital as well. And I think one important thing for us to note here is that this program is intended for our government to extend the savings to core essential providers. We're talking about critical access hospitals, sole community hospitals, health centers, dish hospitals like us who serve a high percentage of uncompensated, uninsured care. With the amount of acute care hospitals that are there, a third of them are dish hospitals like us. And out of that percentage, we provide over 60% of that uncompensated care overall. So when you look at the amount of hospitals and how much care is provided, you can see that unproportional, that cost uptake that we are taking losses on. But we are there for that purpose, to take care of the patients in our community who does not have access to the health care that they should. So to be a little bit more specific, for the folks who are participating within this program, it's important to note we are the covered entities. What we have to uphold is our program integrity. Obviously, the program brings back a lot of savings. So to take advantage of this program, to reap its benefits, you have to uphold the integrity and the compliance piece of it. And that is also to provide that healthcare access. As we grow in our program, we try to strategize to where we can pull in financially better savings through our clinical teams, through our growth in departments, through our contracts with pharmacies. Those are our responsibilities in being able to participate within this program. Your drug manufacturers, again, those are the folks that are enabling this program because they are participating with Medicaid and Medicare Part B. They are required to participate within this program. And that was a way for Congress to enact that cost savings to reach our safety net providers. As well, drug manufacturers are relied upon providing their costs, their average manufacturer prices, the rebates that they provide to Medicaid, and that essentially is the best price. So when they provide that on a quarterly basis, that is how 340B prices are calculated. So it gets calculated quarterly by them reporting their average prices and the rebates to Hersa, and Hersa holds them accountable by calculating all of that to ensure that we're getting our 340B ceiling prices for all the drugs that are eligible. As well, drug manufacturers provide the rebates to state Medicaid. So if you remember, they either have state Medicaid to give rebates to, or they have safety net hospitals that they have to give drug discounts to. So with our Medicaid patients, for certain entities, they provide the rebates on the back end. So essentially Medicaid is getting that best price calculation in the end. We are getting the front end benefits of that with that drug procurement.
It really boggles my mind how a drug like Oxford is $20,000 on WAC and a nickel on 340B. Have you ever heard of any examples of how they arrive at that?
It is a calculation. Yes. So I had a question from Amy as far as the drugs that has a huge disparity in price. So we're talking about our oncology areas, our infusion areas. It is a huge margin as far as a list price and the 340B price. The 340B price essentially are the abilities of that best price they can extend to Medicaid. And so because they can extend that to Medicaid, that is required for them to extend it to us. Obviously, I think drug manufacturers, there's a lot more in play with brand name drugs, how it becomes generic. There are strategies as to how they structure those costs. But that's another presentation there. But yes, those are accurate. It might seem astronomical as to how different they are. That is what drug manufacturers are able to supply to the Medicaid program. And while you had mentioned that 340B prices in general, you can expect about 25 to 50% off in that list price. Obviously, with your big blockbuster drugs, there is a larger gap in that margin. Yes.
So for the rebates to state Medicaids, is this why, maybe, I don't know if you know the answer to this, but why the formulary shifts? It's like the shifting sand, and this week it's this PPI, and then the next quarter it's this PPI?
Yes. I don't know too much of the details, but, and to repeat, yes.
Sorry, I was trying to yell.
Now, to repeat the question that was just asked, Andrea had asked, so with the fact that drug manufacturers are providing rebates to Medicaid for their beneficiaries for certain drugs, does this somehow cause changes in medications being covered? And my opinion, absolutely. What gets pulled into their formulary and gets covered by Medicaid, they'll readjust. So those will change, contracts will change, pricing will change, new medications and generics will change. And so there is a lot of that background formulary decision that all affects how pricing works. So, but yes, that is a very good question. So within the program, Hersa oversees the players. So we've got our covered entities and our drug manufacturers. Any discrepancies, any audit request, usually Hersa wants the covered entities and the drug manufacturers to reach out to each other first. They want you to work it out, talk it through what is the issue before you bring it up to Hersa. They are also responsible for auditing hospitals, all the health centers, and even drug manufacturers now. It used to be that they audited more on heavily on the covered entity side until it was brought to their attention that, you know, some of these drug price calculations could have discrepancies in them. And to the drug manufacturers, you know, defense, they do provide reimbursements to hospitals after they make corrections on their calculations. So they'll reach back to hospitals and say, hey, for even I've seen 5 years back that we've recalculated this error and we're going to credit your wholesaler. So they do uphold that. There are repercussions if you as a hospital report that, and they are then audited by Hersa. So your other players within this program, your state Medicaid, and I think we kind of touched on this as far as them being the other component of getting that rebate from drug manufacturers. With the way that reimbursements get, covered entities and state Medicaids do play an integral role together, and we'll discuss that a little bit later. Your other ancillary stakeholders are your wholesalers, pharmacies, and third-party administrators. These folks facilitate how the program is going to work. You have your wholesalers that's servicing you in the hospital, and it's servicing your contract pharmacies. And again, remember, those are your two avenues of pulling in savings in this program. Your pharmacies, those that you've contracted out. For us specifically, we've contracted out to retail pharmacies, specialty pharmacies. As much as we've got in that clinical service, our patients are going everywhere because you can't control where prescriptions are going from your patient. It serves you to have a broad net of contracts with all these external pharmacies. So third-party administrators serve to adjudicate all the data. And there's a lot of data. Just as an FYI, each day within our hospital, we have close to 20,000 lines of encounters, and that's barring corrections. So it's a lot. There is a lot of data integrity that is involved. So that's why it's so complex now that there is a third-party administrator within all of these segments. You've got a third-party administrator for the hospital. You've got folks pulling in data from your contract pharmacy and your specialty because it hinges on the program compliance. You have to provide evidence as to why you are pulling in these drug discounts for your patients. So. I want to touch a little bit about the types of entities that are qualified within the program. Obviously, when you can see here, your health centers are focused on your specialized patient population. You've got the Black Lung clinics, you've got your Ryan White HIV clinics, your STD clinics. That is actually next door to us, if you guys are familiar with that. HTC centers, you'll hear great stories of patients of how this program has provided essential care and financial support, because these patients are obviously hit with so much of that drug financial burden. So this is an avenue that has helped these patient populations. And you'll see here on the hospital side. So hospitals in its category has a little bit of a different requirement as these health centers do. Essentially, with hospitals, they are required to be publicly owned and nonprofit. There has to be some governmental contract or body that services that. And so all of these dish hospitals are nonprofit, some sort of government control that is involved. So when you look at all of these entities, these are all folks who are providing care to folks who have barriers to healthcare in our community. Talking about transportation issues, interpretation issues, as far as understanding. So you're hitting a large portion of patients that might not otherwise be able to access this healthcare, and that's why this program is intended to provide those fundings, so the hospitals or the health centers can provide an extended service, provide something that extends to their patient population, increase comprehensive clinical services like we've got our metabolic center that reaches out to diabetes care. Our FQHC, they provide all sorts of primary care that, you know, patients, no matter what, they can be put on a sliding scale to get whatever healthcare that's need, pediatric, dental. So it's very extensive in what they can provide. And this is in particular to Erlanger. We have 4 entities within our health system. Main one is our Erlanger Medical Center. And we are a dish. We have to meet that threshold of serving a certain load of uncompensated, uninsured patient percentage. The percentage threshold is 11.75%, and we well surpass that. And I think you guys know, in being able to reach our patients and assisting them with whatever pharmacy clinical services that you're seeing our patients flow in. Our Dodson Southside Community Center is our federally qualified health center. So they have to operate by certain grants. So they have to provide certain percentages of care and how they're using their funding. So it's very unique as far as the requirements of being able to use this program and how they have to provide evidence of how they're upholding their part within this program. Our Bledsoe and our Murphy Medical Center are critical access. They do have certain rules that are different from the other entities. They have certain exclusions to the drugs that they could pull in 340B prices for. So all these rules make it complex if it isn't already so. When you're considering from one institution to the next, and when you talk about operations logistics wise, it poses a very interesting learning experiences. Yes, so for our Erlanger Medical Center, we contain East, Children's, and North. So Bledsoe is on its own as a critical access hospital. And when you break it down like that, that sounds simple, but when you're talking about data, drug usage, procurement, it's a nice matrix. So the important piece within this program, as I'd mentioned, is keeping our program integrity. Obviously, with the savings that are pulled in here, it does as well to not get cited by Hersa and get this program taken away. The 3 main areas of compliance that Hersa will come in and look at is, 1, your eligibility. They are so granular to the fact that even though Erlanger Medical Center is qualified as a 340B hospital, that doesn't mean our new clinic that's opened up in Cleveland or Dalton is qualified. Everything hinges on additional factors as far as cost reports, how that appears yearly. And when that is done, you have to have a stepwise fashion of how that gets pulled into the program. So just because we are a 340B hospital, and I get that a lot, we are a 340B hospital, why can't we get this drug discount? It's like, Well, there's a few more things to that. And unfortunately, they don't stick around to hear the rest of it. Um, so facilities, sites, specific requirements, that is what pulls heavily in the eligibility component that we get audited on. The second piece is diversion. So diversion, you see here just 2 points, but it essentially means that if for some reason a medication was used or purchased and it should not go to that patient and qualify for 340B, you are not compliant. Well, I think we all know there's a few steps in between from when that drug gets ordered and how that drugs get to our patient and administered, whether documented well or not. So that drug of diversion has about 20 points where you could be non-compliant if they're looking for that documentation piece. And the third piece here is your duplicate discounts. So earlier when we talked about within this program, you've got state Medicaid getting rebates for Medicaid patients on the back end, and we get that drug discount on the front end. The prohibition is that the drug manufacturer is not exposed to two inflictions. They do not have to give a rebate and give hospitals a discount for that same patient's drug. So that is a big prohibition within the program. So this focuses on just some of the legs as far as why it's so difficult to uphold that integrity within that med administration process. You think BCMA was bad? That's one component of this. So when you go and track down how drugs get documented, you're looking at, okay, within your hospital, that patients get administered that Rocephin or whatever dose. All of that data passes through to our EMR. So Epic captures all of that. So the finer pieces in that is that you have to contain where was this patient, because remember, again, one of the main things is it has to be outpatient. Anything inpatient does not qualify for the program. The data also has to contain the accurate product. The program is nuanced to the fact that it has to be the exact 11-digit NDC. That's why we bug you about NDCs if you have been bugged by us. If you proclaim that you have used X number of drugs to this exact 11-digit NDC, and that was somehow incorrectly built and not documented or scanned by your nurses, that's a non-compliance issue. So that's a whole host of data integrity that could take a good bit of time. After all that data goes through your EMR, then goes to our third party, they pretty much count your credits. Each time you have a patient use something that qualifies, you get a credit. Each credit that builds up a whole package, you get that discount. So it works in that fashion. So through this process, you got your data, you build up your credits, then you can purchase it. So that's why it flows into our supplier and our manufacturers. Issues through that, you've got sites who doesn't know, who aren't aware, accounts that have been created over time, that is 340B, and doesn't have that full knowledge of, oh, you have to have a credit to make purchase. So it's not unusual to find places that might inadvertently and historically just go on purchase on one account. And what that creates is that usage of the program that isn't eligible and is a diversion. So you're talking about a whole gamut of pharmacy involvement, your IT chart involvement, your purchasers, your buyers, and then multiply that by however many sites that you have within your health system. So the communication piece is obviously something that needs to be strengthened within any institution as far as getting that 340B program compliance at a good level. So Hersa audits. So that piece touched on just the components of capturing data integrity. Hersa audits, I love what Katie said when we had a letter of Hersa audit last October. Katie said that this was like JCO DNV on steroids. And I could, not having been through all of that step, I can see because Hersa audits are extensive. They'll touch every piece within your hospital, from your financial team, your credentialing team, your EHR, eChart teams. Everything within your system touches all the data, all the wholesaler accounts. They pull all of that data and make sure that you're compliant within the program. So when we had our HRSA letter in October, within that second day, we had most of our chiefs together and pulling the teams and making sure, do we have everyone on board? You're getting 6 months, about 6 months worth of data that they give you 2 to 3 weeks to gather. And so that data gets passed over to them down to the granular NDC level, what you bought, when you bought it. And they've got built-in algorithms to where they can hone in on areas that might be weaknesses, products that they've seen to be issues for other hospitals. So they know what they're looking for. HRSA brought on the Bazell Group. Essentially in 2012, they contracted with pharmacists, pharmacy technicians, who are great and know where the weaknesses are within the hospital. So our auditor was a pharmacy director for, I think it was close to 40 years. So he knows what areas to look for. And as horrible as it was to go through that, I think, to take away from it is that how do we strengthen our institution with findings or any comments that are brought back? Luckily, we had no findings for Erlanger Medical Center. It's just some areas of improvement. So it's great to get that feedback. And I think they get that bad guy image as far as auditors coming in, unreasonable. But, in the end, in talking to them and working through the process, it was great to see that, okay, they're just upholding the program. They perform about 200 audits a year of hospitals. I think manufacturer audits are much less. I don't know what the last count was, but I want to say around like under 10 or so. Obviously, the amount of hospitals and participants are a little bit different from the manufacturer side. But I think for what they came in and did, they are a key role in keeping our hospitals, accountable for participating within the program. So really, why does this all matter? Why is it important to us? And it's the financial savings. Our hospital outpatient areas, you're talking about our ED, our infusion centers, our children's infusion centers, all those pediatric clinic specialties over in the Kennedy building. Those pull the drug procurement savings as well as the reimbursement savings that comes back. So reimbursement wise for 340B, you get reimbursed as you normally would on the most part. So you're getting that drug savings and you get reimbursed as you would. So not only did you save on that drug, you can also get that benefit of that margin and reimbursement there. And as far as patient assistance, we've got a community benefit program set up within our retail pharmacy in the hospital and within our FQHC. This provides tremendous help for our patients. Financially wise, I think we help our patients about at least $1.5 million in drug costs by having this program in place. So our health centers, most of their patients are getting their medications at a 340B price plus a little dispensing fee attached to it. So very minimal costs to keep them within their therapies and to keep their health care on a compliant measure. These safety net services that we're able to extend to our rehabilitation services, all the orthopedic services, all the children's services. These savings essentially bring back that capability for our institution and for others. You'll hear a lot of rural health and Soul hospitals that say the program essentially keeps their lights on and keeps their doors open. So these hospitals operate on hardly any operational budget. And to get that piece of drug savings is a piece that's allowing them to stay open and to provide some care for areas where patients would have to drive hours and hours for any sort of health care. And that's why, this was created and why it matters so much. And I think to move on from that, what's important to realize is, the savings that we are able to bring back from contract pharmacy. It's playing a bigger role within the 340B program. its growth, I think, has been under a lot of scrutiny. With its change within 2010, a hospital used to be able to have one contract pharmacy. After that, it opened up to a limitless contract pharmacy scene. So that growth from 2010 to 2020, I believe the statistics were where within the program itself, there were 2,000-ish around there contract pharmacies, and now it's gone over to 25,000. So it's a tremendous growth. Obviously, it is a savings to the institution, but also, like I'd mentioned, it is savings to our patients. Not all hospitals enable a program like that we have within our hospital and the FQHC. So it depends on the institution and the teams that they're able to implement these types of programs. But your contract pharmacies bring a lot of savings through the retail, the specialty, but that hinges on several factors. Unfortunately, the contract pharmacy scene can be a player within the program that goes unnoticed. It pulls a lot of savings. And when you're a smaller institution, you don't have enough leverage to negotiate the fees to get involved in this. Some institutions, that large, whatever down the street corporate pharmacy that's in your town. So even though this is a savings avenue, I think the other key players know how to strategize and pull the savings that was intended in this program to hit your hospitals, to hit your health centers. So they're the other folks who are getting a piece of the pie, but they're not held accountable like we are. They are not going to be audited by HRSA. I just wanted to mention, as far as contract pharmacies, the fees that like I had mentioned, they can negotiate different types of fees. You can have back-end charges for the drugs that are involved. You could change the medications and the insurers that are eligible within the program. So even though it brings back a lot of savings, it takes a lot of strategy when we work with our contract pharmacy. So, knowledge check. Anyone tell me what term is used to describe when we get a 340B discount from the manufacturer and or your state Medicaid agency also obtains a discount? See, yes, this is your, duplicate discount. So that's a big prohibition that you have to avoid. Our hospital actually is going through a process to where we change our status, FYI, to where we can get eligibility for our Medicaid patients. This changes a lot of how you logistically validate 340B eligibility. So it involves a lot of IT, financial support for hospitals to pull this piece in. But it is one of those areas that you have to be careful for, is to avoid that getting a discount and also Medicaid getting a discount. That brings us into what has been happening now. Since last year, I think that has been the most 340B news I'd ever seen, to where it hits somewhat of mainstream. If you're reading some sort of pharmacy, drug type of news portal, you'll see some flash of 340B or watching certain news. Last year, Eli Lilly started this process to where they pulled their drugs from having 340B eligibility within contract pharmacy realm. So if you remember, you've got your savings from the hospital or your savings from your contracts that you build relationships with. Essentially, they did not agree with that extension to the contract pharmacy side. They wanted to remove their products from that eligibility. Started with Eli, went on to AstraZeneca, Novo Nordisk, Sanofi, Novartis. So in the end, we had 6 major drug manufacturers that pulled that relationship. So not only were we getting huge financial impacts as an institution, we also had patients that were impacted. And I believe, our clinical team here, I got communication back. I was like, oh, hey, we had patients that could get insulin, and you're talking about Eli Lilly, Novo Nordisk, and Sanofi. Those are your insulin products right there. So that pulled, the rug under from our patients when they were essentially able to get their insulin vial for under $15, $20 to now a full price. Because our patients have no insurance usually, or they're low income Medicare patients that has to pay a huge copay. So that was a huge, huge impact. And it's just slowly progressed and unfolded from August until end of last year, around December. There's been some smaller movements from drug manufacturers in this process, but so far with this, the impact has been felt nationwide. We've got hospitals that have built programs even larger than this that facilitate that financial assistance for patients that are just unable to be able to provide that assistance for your patients. So this whole process is in litigation right now. So the only exceptions that we have is to directly reach out to these drug manufacturers. That's why for us at Erlanger, we've worked to make some communications to some of these manufacturers, had personal exceptions to where it could still be supplied with our contracted pharmacy in the hospital. And it was just, I guess, interesting to me that when I talked to some of these folks, they were surprised that hospitals were doing this. They have an image or a message that, 340B entities are just pulling in all these savings and not helping patients. Whether that's propaganda or actually folks don't know, I can understand the program's complex, but that was a surprising message when I talked to some of these folks that hospitals are actually using these benefits and helping our patients directly. So as I mentioned, this has gone through a lot of litigation and it will be ongoing. Katie, do you have a question?
There was a misunderstanding about what hospitals do with the money. Every time Erlanger or Crawford is able to save money in any way, you have to think about all of the services and the care that we provide essentially for free. So this is the money that helps us take care of all the patients for free. So that's the reason those savings are so important for hospitals that actually qualify for it. And Doc, will you tell everybody an estimate of the lost savings due to these manufacturer actions for us?
So the savings has been, from what we've been able to capture, on the upwards of millions. I would say from what we can see, it's hitting towards $10 million as far as what has been impacted our system. Not everything can be captured because, again, you're talking about contract pharmacies. You're relying on external third party with data. What was decline? You have to analyze exactly what this pulls back to. So you're considering patients' reimbursement to get that type of calculation. So it was a tremendous impact. Unfortunately, with everything that's happened, Hersa, with the new administration, I think it's been a slow process. With that change in January, we've had a little bit more support, I would say, on the CE side. Hersa has recently enacted a administrative dispute resolution. So that's basically allowing hospitals to go about bringing a lawsuit as to why drug manufacturers have done something against the 340B statutes. This was brought to court by drug manufacturers, obviously. You've got lobbyists on both sides. So it's a very hot topic. You've got huge blockbuster pharma companies that are trying to make changes to the program. And you've got your 340B entities here that has been able to rely on a financial resource for such a long time. And it's a huge impact when you're talking about institutions that has bare minimum operating budgets. And this is supplying, like Katie had mentioned, this saving has been able to provide the care that we can extend to our patients, the uncompensated, uninsured care. And we know that. We essentially know that we take a loss when we pull in Medicaid patients, the uninsured patients around our area. And that's what we do. That's what we're here for. And we serve a high percentage of that. I know in children's, having used to work there, we have, at least last time I remember, about 50% Medicaid population. But, through those savings, we've had patients who's come in and received oncology service where we've got bare minimum reimbursements on. So these are the drug savings that it eventually pulls back to provide that hospital the ability to keep on continuing care for these patients. Yes.
Sorry, I have a quick question. Sorry if this is dumb, but if certain hospitals have their own outpatient pharmacies and they're not contracting with the CVS's and the Walgreens of the world, do those outpatient pharmacies still get to keep that 340B
Yeah, that's a
benefit to Merlin or pursuing something like that?
yes. So Bree had a great question. So for institutions to where they have their own contract pharmacy, in-house type of retail front to provide that prescription care, are they impacted by all of this piece with drug manufacturers? It has been no. They have allowed that. So if we had our own Erlanger pharmacies, we would not have had this much of an impact over the last 6 months. So that is something that for larger institutions and for institutions, I believe the last ASHP statistics were that if you were like over an 800 bed hospital, they generally found like upwards of 85% of them having their own pharmacy for outpatient care. So it is an avenue that certain hospitals have strategized well in continuing that care. And it only increases their ability to provide that care, especially when you've got your clinical pharmacists who could join the medical team and continue your complex patients. Has that ability to dispense those that only enables you to gain more savings by being in this program. But yes, it's a great question. So there's a lot of scrutiny, like I had mentioned. Drug manufacturers are trying to upend this program. Obviously, a lot of America's essential hospitals and 340B organizations and health centers have tried to fight this. It's just been a back and forth process. I probably think it's going to extend out well to the end of the year. So all in all, my personal opinion, does the program need more transparency? Sure. I mean, we have organically, institutions have provided, volunteered additional information and say, okay, we use our savings to help these patients here. We've opened X services over here. So it's just happened over time because you get so much, I guess, misconstrued messages as to the program's intent, that a lot of organizations have volunteered this information as to why it is actually needed and necessary. That's not to say you have organizations that might not use their savings well. So if we have reform, if they want better upkeep of how much savings an institution is having and how are you allocating your financial savings, how are you realizing this and keeping this in a operationally well-manned service, I think that could only help. So that's my personal opinion. Some folks feel like the program doesn't need to be touched. So you've got varying degrees as far as what changes has to happen. So this program was created in 1992, quite a while. There's been a few changes along the way. So possibly there could be some more transparency as far as participants providing, the financials. How does this hit your bottom line? What are you using it for? And also the other piece I feel like is important is the market standardization. So within this whole scheme of 340B savings, you've got your third-party administrators who are pulling in all the data. You've got your contract pharmacies that are fulfilling their relationships. They get a good chunk of this pie in savings, but they're not held to the oversight and the compliance piece within the program. So that leaves a lot of room for oversight and change within the program, I feel. All right. I think that's enough of 340B that you could take for the day. If you are still interested, there are a couple of sites that you can go in and read more in depth about the Section 340B Health and Services Act. Any other questions? Thank you so much for all the great questions throughout the presentation. And just as an FYI for us, the program brings in well over half of our uncompensated, uninsured care. Very impactful.
Okay, now, one thing I was gonna ask you, contract policy numbers, just to kind of demonstrate the growth that we've seen in contract policy relationships, can you tell everybody